The research paper that I praised for part A of this assignment was the effect of vitamin D supplementation on depression in older Australian adults. So vitamin D has been associated with almost every imaginable health outcome. Emerging evidence suggests the biological form of vitamin D influences the production of serotonin and dopamine, which are important regulators of brain function, suggesting that vitamin D deficiency might be associated with the risk and or severity of depressive symptoms. The D-Health trial is a large placebo-controlled trial of elderly residents of Australia, which aims to determine whether increasing the mean vitamin D concentration in the general population through widespread supplementation would result in improved health outcomes. This study uses the data from the D-Health trial to explore the depressive symptoms and incident antidepressant use of older adults living in Australia. The research question that was asked was, in Australian adults between the ages of 60 to 84, is vitamin D3 supplementation compared with placebo supplementation effective in reducing depressive symptoms and incidence of antidepressant use? Invitations were sent to 421,207 adults between 60 to 79 who were randomly selected from the Australian electoral roll to participate in the RCT. Volunteers between 60 to 84 could also participate. Recruitment began in January 2014. The intervention period ended in Feb 2020. Participants were excluded if they had previous or current diagnosis of hypercalcemia, hyperparathyroidism, kidney stones, osteomalacia, or sarcoidosis, or had a daily intake of more than 500 international units of vitamin D supplement. Baseline characteristics were determined from a health and lifestyle questionnaire completed after recruitment. Groups were formed using computer-generated randomization, where participants, investigators, and analysts were blinded to allocation. Groupings were stratified by age, sex, and the state of residence. Eligible participants were allocated to either vitamin D or placebo groups. 12 tablets, the same for placebo and intervention, were mailed annually for 5 years. Tablets were taken on the first day of each month. The PHQ-9 was completed at 1, 2, and 5 years after enrolment to measure depression. A higher score indicates a more severe depression. PBS records were used to indicate which participants were taking medication for depression. Analysis followed the intention to treat principle. 21,315 people were randomized. Data was withdrawn for 5 people, leaving 21,310 randomized into placebo or vitamin D groupings. 20,487 people were included in the analysis of the PHQ-9 scores. Participants were not analysed due to missing PHQ-9 scores for all surveys. 16,670 were analysed for antidepressant use. Exclusions included no consent for PBS linkage, people who identified as prevalent users of antidepressants, and people who had died within 6 months of randomisation. Final analysis showed vitamin D supplementation had no effect on PHQ-9 scores. As can be seen, the mean PHQ-9 scores for vitamin D and placebo are 2.63 and 2.61 respectively, the mean difference therefore being 0.02. Because the confidence interval from negative 0.06 to 0.11 includes the mean difference of 0, as shown here in the forest plot. The conclusion is there is no difference between PHQ-9 scores of the intervention and placebo groups. The effect was therefore not significant. Subgroup analysis shows vitamin D supplementation improved PHQ-9 scores in those taking antidepressants. Analysis of the mean difference, confidence interval, and forest plot together with P interaction of 0.02 indicates supplementation had some significance. Similarly, examination of mean difference confidence intervals, the forest plot, and P interaction shows that vitamin D supplementation had an unfavourable effect on participants with a BMI less than 25 kilograms per metre squared. This RCT used an equal 1-to-1 random allocation procedure, utilising a computer-generated program to place participants into vitamin D or placebo groups that appeared similar at baseline. Participants, staff, and investigators and analysts were blinded to group allocation, and analysts were further blinded until after analysis of results. An intention to treat analysis was used. Although there was a loss of outcome data, incomplete data excluded from analysis, withdrawals from the trial, and imputed PHQ-9 scores, 96% of data was analysed in both groups. All participants and researchers were blinded throughout the trial. Once enrolled to prevent withdrawal from the study, participants were allowed to take up to 2,000 international units per day if prescribed. Exclusion of off-trial vitamin D supplements would reduce performance bias. The study indicates that people analysing the outcomes were blinded until after the analysis was complete. Reporting bias is minimised because data was analysed by the intervention to treat principle using the mixed models for repeated measures. Clinical recommendations. Our findings are likely to be broadly generalisable to the Australian population, but should not be extrapolated to populations with a higher prevalence of vitamin D deficiency and/or in populations where a majority of people are non-Caucasian background. Supplementation of depressed patients with adequate vitamin D status and BMI less than 25 kilograms per metre squared due to increased PHQ-9 scores observed may not be recommended. There could be a potential benefit of vitamin D supplementation together with antidepressants, but not as a standalone therapy. For largely pragmatic reasons, participants in the D-Health trial are aged over 60 years, and we are supplementing people for only 5 years. Thus, we will not be able to address the issues of whether vitamin D supplementation of younger people or for a longer period of time has health benefits. All in all, only 5% of the people invited were recruited, which makes it difficult to generalise results to our populations.